Hi, my name is Trini Trong. I'm the Chief Medical Officer of Mount Sinai at Home, which is the joint venture of our home-based care continuum at the Mount Sinai Hospital health system. It includes hospital at home, rehab at home, palliative care at home, and home care, and the other home-based care as well.
Awesome. Welcome.
Hi, Mike Maniaci. I'm from Mayo Clinic. I'm a hospitalist by trade. I'm the medical director of the physical hospital of Mayo Clinic in Florida. I'm also the enterprise lead for virtual care. I run our home hospital program and a lot of our virtual care modalities with the Center of Digital Health. I'm happy to be here.
Rachel Weisberg, I am head of our healthcare provider and growth strategy at Natera. We are working on a device that does touchless monitoring, and we're working inside hospitals as well as at the home.
Hi, everyone. Seth Gabarro, Head of Health System Growth for Best Buy Health. Rasu aptly described everything we do, so I don't need to offer any more detail there. We work with health systems to support from a technology and services perspective, really orienting care as that primary venue for where things are being provided and received.
Awesome. So any quick burning questions before we get started? Huh? All right, good. So I just love for all of you to maybe comment and expand on, maybe starting with the healthcare delivery partners here. Based on what you heard Rasu say, how much of that seems like science fiction to you versus how much like, oh yeah, they're doing it and the rest of us can also do it as well. So we'll start with you and then.
Sure. I would say that Rasu, I see you at home. That is absolutely amazing. And I will be talking with you about that more. Definitely. As you know, Sinai really did some of the foundational work back in 2014, 2018. Our geriatrics team had this CMMI grant to study the feasibility and safety of this model in the United States. And this model existed around the world for a very long time and it still is. But we studied that initially and found that it was effective and it was safe. Patients love it. And if you do the 30-day bundle, post-acute care, if you do that, the cost is less as well. The acute side, not so much. I think at least the same as a brick and mortar, but then the saving is in the post-acute side. Patients are less likely to have complications. Patients are less likely to need subacute care, which is post-rehab, all those SAR, we call it here. And the biggest thing is that patients absolutely love the program. And we continue to expand. I think since the pandemic, some of the folks who involved initial studies really helped with CMS and some other folks, and Bruce Leff and Linda Sherry and Alsu also helped with initial CMS waiver as well. We have gone through a few iterations, but right now we do have these programs continue to grow, and we continue to explore, not ICU at home, but we do cancer at home, so like oncology at home, exploring and then starting surgical at home, ENT, and we're also working on cardiac as well.
What are your reimbursement fears for this year on the reimbursement? Obviously, the program is going to get sunsetted in May. What happens after that for you guys?
Yeah. So we did the program before the waiver.
Oh, you did? Okay, great.
So from 2018 to 2020, we negotiated with payers to provide bundle care. So which is what a lot of us talk about. The patient is not just this isolated episodic care. The patient's care really spans the entire from acute to post-acute. So that bundle care, we operated during that time, 2018, 2020 in that. Should the waiver not happen, which I think it will happen, and a lot of us are very certain that it will happen. It has broad support, and with all of your support and continue to urge your congressmen and senators, it will pass. But let's say in the worst case scenario, in that maybe 1%, then we continue to go back to where we were before. We still have some of those contracts where we provide the care for their patients. You pay whatever the amount you would have paid for the patient in the hospital. We can provide that, and there are, previously we did have some discount with that DRG payment. The other thing is there is a lot of health systems also use this as a continuation or early discharge program where you take care of the patients and now you have the infrastructure to discharge them earlier and save the length of stay, save your day, a bed day save. So let's say a typical pneumonia will be in the hospital for 4 days. You could have that patient in the hospital for 2 days and you discharge, and then you have your program to see those patients in the home for the next 2 days or 3 days. That's not hospital at home per se, but it's continuation of like early discharge program. And some programs did that before the waiver as well. But I've talked too much. I'm gonna get Mike to continue.
Yeah, Michael, before you jump in on the details, I'd just love for you to summarize where Mayo sits in terms of hospital at home from what you're covering. And you also have a platform called the Mayo Platform run by John. So talk a little bit about that platform and what do you do with it in Florida?
So the purpose of the platform is to build something and then share it with others and do the same foundation throughout, because as we found out that many different programs, and the big problem with digital care nowadays and virtual care is everything's built in silos and nothing talks to each other. And even at Mayo Clinic, I have Teledoc and Caregility and Medically Home and Bioformis at 6 different sites doing 6 different things, and they don't talk to each other. So a platform was said, let's level the playing field. Let's build our own digital platform where data can be shared and used to build up structure. And then we'll be agnostic of product, agnostic of vendor, agnostic of care programs. That's the premise of that is a data platform and a foundation that we can put all these things in, and you can be agnostic. So you can switch as the technologies get better over time, as we've heard. You can move on to the next thing and not be worried about being lost or shutting something down. At Mayo Clinic, we run across the country. From Mayo Clinic in Florida is where our command center is. We do a virtual hybrid program, which means we have virtual bedside nurses, virtual physicians, and then supply chain bubbles of paramedics and nurses in the field that live in Arizona, Wisconsin, Minnesota, and in Jacksonville, and they go treat our patients. So one physician like myself can treat 15, 20 patients across the country, as opposed to going house to house to house. That's why the old system of hospital home didn't work so well, is you were stretched by geography and you could not see all these things. We have a census in our Florida campus of about 20 to 25 patients for one hospital, 300 beds. We'll talk about scale in a second and what Rasu talked about. And then we do about 8 to 10 patients in our smaller hospitals in Arizona and Wisconsin. That's all controlled by one set of physicians and nurses. The question I was going to ask Rasu, which is scalability is very difficult with this, and it's something we struggle with both on the technology side and then on patient side, because Rasu has the biggest program in the country. I'll give him credit on that, 80 to 100 patient average daily census. But that also pulls from 15 hospitals. And, I'm undershooting, but like 2,000 beds. So if you had a 2,000 bed hospital and you had 100 patients at home, that's 5% of your patients. But we're saying home hospital should be 15, 20, 25% of the 1 in 4 patients should be going home and not into the physical hospital. How do we reach that scale? That's the thing we're all trying to figure out. It's going to be driven by the workforce. You need the people to take care of them. The technology, you have to be orchestrate care in the home that plays beautifully like a true orchestra, or else it doesn't work well for high acuity patients, just like ICU at home. That's fantastic. We take care of bone marrow transplant patients, post kidney transplant patients, these high acuity patients as well. But if something goes wrong, you have to have stuff very quickly. Easy when you're taking care of 5 people in a city, but when you're taking care of 500, much, much more difficult across geography. And then you have to scale really moves from acceptability to preferability. So just because we can do it and it becomes acceptable to providers and patients doesn't mean they want to do it. So if we want to get true scale, 500, 1,000 patients in your home hospital, 25% of your beds, it has to be the thing that everyone wants to do. Just like, Uber. I didn't use it for the first 2 years. I'm like, are they going to show up? Is it going to happen? I didn't know. But now taxis do the wrong thing and it's Uber every single time because I can see it, I can follow it, I know what is going on. We have to have that same mindset, both our providers and our patients, to where we make it so easy, so streamlined, that they're going to be at home and be like, man, I'm not going to go to a building. They're going to come to me and I'm going to get my health care. Once that happens, then scale will drive itself.
Nice. Rasu, we'll let you chime in a second. Yeah. Rachel, talk a little bit about what Natera does first and how it enables these kinds of remote care possibilities. And then what I like about what Natera does is you have enough customers where their level of sophistication, be able to pull off the kinds of things that Michael just mentioned at scale. So just start a little bit with what did Natera do, and then how do you enable this hospital at home using that kind of technology?
So Natera is a device that is mounted above, or it's put above a patient or behind a patient, and it's continuously monitoring the vital signs as well as activity and the motion of the patient without any interaction from the caregiver or the patient itself. Um, what it's doing is it's really taking away the need for somebody to go in there and check those vital signs, right? Or check, how is this patient doing? So we can continuously see, as we're looking at that person, no matter where they are, assuming they have to be under a device. So not anywhere, but as long as they're within line of sight to our device, we're able to see trends in what's happening with that patient. So as they're deteriorating, as things are changing, we see those changes, and the care teams are notified of those changes so that you can then take action on those changes. Um, I think the biggest challenge just of the system overall, and this is like Russ who said it, and I loved your term. It was, I've always called it the air traffic control center. I love that you called it the care traffic control center, but you have to have some kind of centralized virtual care team that's able to see what's going on and be able to say, hey, we've got an issue over here, we've got an issue over here, how do we respond to that? We are pushing into the home, but where we are today, and I like to think of the home as, where the patient is. What's fascinating to me, and you probably all know this, so if I'm saying something that I apologize, but I just learned this. There's 1 million acute beds and there's 1 million post-acute beds. That's what we have. That's it. We have a lot larger population of people than 2 million beds that need care. The home doesn't necessarily mean to be like, my home right now is obviously a nice home. I'm younger. I'm not in assisted living or independent living, but we're taking a stance of starting in the home where our elderly population is today. And that's either in assisted living or independent living, even in a skilled nursing facility that's really become a home for many of our patients. We've started there, and I don't know what the right term is. It's more of a control. I call it more of a controlled environment, because if we can figure out that space, we have the ability to do more scale. Obviously, it's easier in volume. We're able to get our devices there, manage our devices, support our devices, have that central command center working with the health system and hospitals that we work with today to build that. The home, obviously, and this is where the guy on my left becomes so, my best friend. And stalking him for a while, so I'm excited to be sitting next to him. But this is where we believe somebody like Best Buy becomes so pivotal to our success. So we're all speaking to how great you are, Seth. But the idea of, how do we get into the home? How do we, now we're dealing with Russ, who said it best, is someone's privacy, right? Now we're entering this facility that may not have connectivity, may not even have knowledge of how to use technology, and all those socioeconomic factors that go into the home. So that is, I would let you kind of talk through that, but we're looking for the support of that, because I think that's kind of the last mile for us and how we do get into that home.
Yeah, I love it. And in fact, what companies like Natera especially enable is, if you can think it and you can build the workforce around it, the tech is there to handle it, right? That's almost what you got to think now is, it's 2025. Of course we have tech. Of course it's available. But where's the human in the loop? Who's going to get this material out there? Who's going to operate all of that? And that's Seth, tell us a little bit about, so over the last few years, guys rolled that out. Compare Geek Squad versus Best Buy Health. What does that difference look like? And then where does Best Buy see Best Buy Health fitting in their general strategy, and how much could the audience depend on you guys to say, hey man, I got to get into that home, I know what to do, and there's a partner available?
Yeah, sure. Thanks for the question. I'd say largely from an enterprise strategy standpoint, Best Buy is all about deploying technology with a high degree of human touch. And now we're thinking about how that applies to the health system environment. Rasu said it best, that they know what they're really good at. They're experts in clinical care, pathway development, change management within the healthcare system. We know what we're really good at. Our core competencies exist in supply chain, logistics, operating those services at scale. Again, deploying tech with a high degree of human touch, leveraging our Geek Squad infrastructure. So Geek Squad is a very complementary asset to a larger offering that we're able to deploy. The technology infrastructure, that's kind of table stakes. I think Rasu also said that as well. Deploying a technology infrastructure that has a rich ecosystem of connected devices that can bring all that data, forward and offer it and provide it to, to clinical teams in a thoughtful, insightful manner. Integrating that into existing workflows, into the EHR, making it seamless for clinicians to adopt the use of that tech and gain that valuable insight. I think the differentiator that we bring forth is how do we work with a health system from a partnership perspective to, provide this tech, over the threshold in the home, where you have distributed networks of patients receiving care from a hospital home standpoint to post-acute to even chronic populations of several thousand patients. They all require, support around the tech. And so that's where we can come in and be that trusted resource. It's amazing that patients are so willing to accept Geek Squad agents into their home.
Mm-hmm.
They'd rather see the Geek Squad truck parked in their driveway versus a vehicle
ambulance
from the health system, for example. So there's something real about that.
Yeah.
And so again, it all sort of centers for us in tapping into what we've been really good at as an enterprise and applying that to the specific needs that exist with health systems as they think about the complexities and challenges of reaching patients in the home and thinking about how to support not only the clinical operations but a lot of the technical and other operational components that are involved in that.
So as Rasu mentioned, your distribution centers and retail footprint has some benefits. What are the benefits of those particular distribution centers and retail?
Yeah, it's a great question. I mean, this is what we do all day, every day, across our enterprise. We have a major hub in Louisville, Kentucky called Geek Squad City. It's a real place. And we are processing, thousands and thousands of technology orders for our enterprise on a daily basis, supporting imaging for devices for hospitals and hotels and other B2B partners. Within that facility, we have a health carve out where all we're doing is kitting and logistics for our health system partners that are deploying, health and wellness and tech into the home for clinical purposes. And so that sits right on the main line of UPS. It's incredibly well staffed. And so being able to offer a high level of insurance from a logistics perspective to ensure that when a health system needs a kit, when they want to deploy a kit, they have that right inventory. They have devices that are going to work, that are going to be seamless for patients to interact with. And that's been a growth area for us as we think about some of the nuances that exist within healthcare. But because we approach this from a partnership perspective, we really lean into what our partners, from NYP can bring forth, what our partners from HN can bring forth to think about how this really applies to the health system environment.
The important lesson to learn, I think, for us here is that there are lots of things in the health at home where it's not about the healthcare. It's the at-home part of it, right? And I think what you're teaching us here, what Rasu told us about, and tomorrow, I think it's either today or tomorrow, I can't remember which panel, but our friends from CDW are also here. They are also in a similar mode where they can help and say, look, you guys handle all of the clinical part of this, and let us do all the other pieces that are not specifically clinical, or like what Rasu and Advocate is doing is just train us, right? So in that case, Seth, talk a little bit about how much of Best Buy Health is actually health versus Best Buy.
Yeah, I mean, in many ways, the health portion of our business is still, kind of a nimble startup within the confines of a $52 billion retail giant. We have, several, Best Buy Health has existed, believe it or not, for over a decade now. The care at home work that we're doing is somewhat new, is really brought on through a strategic acquisition of Current Health a few years ago, and then obviously accelerated throughout the pandemic. And, moving forward, looking at leveraging opportunities like the CMS acute hospital at home waiver, but really addressing a broader need around capacity constraints, controlling total cost of care through the use of tech and keeping patients at home where it's appropriate. And so, thinking really about how that is going to be fundamental, and not just, it's innovative today, but I think it's going to become core in the way that healthcare is provided and received moving forward. And so, working through with health systems as part of that change management, and then, as more adoption continues to occur, then this becomes the way that care is provided and received for, for certain conditions and diagnoses.
Love it. So, Rasu, if you want to say a few words about the scalability question that Michael brought up, in terms of you trying to get to 400, let's see, it's right there. So if you want to say a few words about that, both from a Sinai perspective as well as Mayo.
Yeah, no, great
I
question.
love a public conversation.
Yeah.
Absolutely. So we should really compare notes and
Yeah.
together scale this.
As always.
I did not get an opportunity to talk about what we're betting on, which is the next 5 years of our journey forward at Advocate Health. So end of last year, we the board what we call our Rewire 2030 strategic plan, and it's now approved and it's now in motion. As part of our Rewire 2030 strategic plan, and the reason we're calling it Rewire is we have to rewire the way that we think, operate, and really execute to these bold ambitions that we have. As part of our Rewire 2030 strategic plan, we have 6 what we're calling strategic differentiators. So how will we be different in the next couple of years? And what would that really look like, right? And one of those 6 strategic differentiators is what we're calling our health at home and wellness. So this bet that I talked about on the stage is a real one. For us, that scale, the question that you're asking is really ingrained now in the next 5-year strategic plan for Advocate Health. And what I talked about earlier in terms of 4xing the size of what is already now one of the largest or the largest hospital health program in the next 2 years is a real one. But I think that is just to your point as well. There is a core element of culture change, right? So we're together pushing the boundaries of culture change within what is a very traditional care delivery paradigm in our industry today. And then the other big accelerant in this will also be payment reform, and we talked a bit about that as well. So my hope is that payers will quickly catch on, the government will quickly catch on and continue to support this as well. Like I said earlier, it is a bipartisan issue, and it is garnering a lot of support already, regardless of whose administration is running the ship for this country. But I think all of those factors will really then lead to that level of adoption where this becomes not just the taxi cab, but that Uber in that example that you're putting.
Yeah, fantastic answer. So I think that if I were to ask Sinai and Mayo, if I made the following proposition that, hey, as you grow, the growth could occur more with, as an example, Best Buy or CDW, et cetera, rather than more physicians and nurses that are already stretched thin, how would you react to that statement? If we said, let's work, if Sinai at home was focused on having a smaller growth of clinicians with a larger partnership growth of these kind of partners, the Natera's of the world, et cetera, and you have to become integration specialists rather than just, quote, hospital specialists. What does that sound like? Does that sound silly, or is that a reasonable strategy going forward?
In fact, I think that's where we need to go. One of the reasons we talk about payers, the culture change and change management of all of that. But one that is very dictated by local regulatory regulations is staffing and who can see the patients in the home. And I think that's where we as a community need to work toward to address that. So for example, here in New York, we have to have a license, like a home care license, to operate and see patients in the home. And those are not just something that you can just apply for. That's about taxi medallion. It's one of those things. 2 is that they have to be nurses. They cannot be community paramedicine. So we can't scale in a sense that we can't just have an MIH of vans that does that for us in New York State. It could change. It could change with all of us asking for it, change with the patients asking for it. And the other aspect is, come to your point, is that staffing. The staffing for hospital at home is quite different than staffing for a regular hospital or an outpatient. I'm talking about nurses in particular, is that these are the nurses who have to be very comfortable addressing all sorts of acuity. Yeah. You could be addressing patient AD or ICU. You could go in and see any situation and you're fine with it. But at the same time, you have to love in-home care, which takes a different phenotype of staffing. So in order to get that group of patient, it's so hard, and we know how stretched out our staffing, um, supply is right now. Like our nurses, it's so hard to hire nurses, and now you're looking for that particular group of of staff is um, i- almost inconceivable. So in order to accelerate, in order to move past this point of being the barrier, you need to integrate. And I absolutely agree. I think that can be technology, can be an accelerant, and we could be partners in this journey. What I would have to say is that as someone who have worked with technology and trying to integrate technology and AI, all these fancy stuff, I would have to say it is not just the technology. It comes down to change management and how to integrate that into the workflow and integrate it in that into infrastructure. You could create the best AI program out there, but it makes it so hard and it's not within the current infrastructure. It would not be as beneficial.
Yeah. I love that answer. And in fact, Michael, I'd love for you to either expand or differentiate yourself in that answer with the idea that maybe if we become integration specialists, that we don't have to grow all the healthcare except for regulatory problems. We can't get around regulatory regimes.
Sure.
How does that fit in
So-
Mayo world?
We have a huge problem in this country. As you heard, 1 million beds, hospital beds. We don't have enough buildings and beds. We don't have enough physicians, and we definitely don't have enough nurses. But we have an aging 350 million person population. It's only getting bigger. So we're going to have to change the way we do things. And home hospital and this decentralized world of healthcare delivery is that movement to try something different. And it's based upon technology, which is necessary to push it forward so that I can see 20, 30 people because I'm a limited resource. My nurse is a limited resource. Nursing shouldn't be at the bedside if they don't need to be. They can be virtual and do 40% of their job, with their brains and the rest in person. So we have enough. But this is where we have to go because we have no option. Now, where are we going to go beyond that? Because again, like you said, so home hospital and decentralizing healthcare is only the first step. It's going to partner with where we're going with AI and driving care plans so that in the future, we're building the infrastructure to get things outside our buildings and the regulatory and payment processes. Our partners here in technology will also help us to build the Ask Mayo at Home, chatbot, so that when you have a bladder infection at home 5-10 years from now, as opposed to being admitted to home hospital and still having resources of physical nursing and a physician and all this virtual stuff, if you're lower grade, you'll say, hey, Mayo chatbot, I feel sick. Well, let me send a little drone to your house and drop off this blood kit and this urine sample device because by my screening scan, you have a temperature by our camera technology and your heart rate's down a bit. Drone comes 5 minutes later, give a couple drops of blood, you pee in a cup. You have a UTI, your health records, you are susceptible to this antibiotic. Another drone drops off a self-injectable antibiotic pen, just like Ozempic. You take it yourself, and the patients actually become their own physicians with the help of augmented. And if they get better, great. If they don't get better, then virtual visits in the next tier of care. That's what we're going to have to do because we don't have enough resources to reach everybody who's going to get sick. That's running out of time. So we have to build a whole new system of healthcare delivery and the AI that's not going to replace us, but it's going to assist us to see many more people and drive this forward. That's what we need in this country, or else we're going to be in big trouble in 5-10 years.
Yeah, if you're engineers in the room, I hope you're taking notes. I mean, gave you 9 different company ideas right there.
Yeah.
Grace, go ahead, and then I'll have these guys. Did you have one to say?
I just
something?
wanted to offer one
please.
complimentary viewpoint to what Dr. Miyachi said, and couldn't agree more, right? The technology that we're deploying, I think, is really intended to make your limited resources more efficient.
Exactly.
Right. And so that's from a clinical perspective, but also from an operational perspective. So you think about, in particular home hospital, everything that goes into supporting a patient within the home, meals, DME, pharmacy, all of that. Right now it's very manual to coordinate all the services. So we're in the works of developing, kind of an additional software platform that will sit alongside our clinical platform to help, kind of orchestrate some of those activities, make it more efficient, drive automation into that, have it, provide the visibility to patients and providers and care teams so they're not, kind of having to manage that manually on the back end, which is the reality today of a lot of how that works. But then it's beyond just deploying the technology and then offering, the service infrastructure to complement that, to kind of offload burdensome tasks from clinical teams so they can be, more efficient with their time, which is also a limited resource at the end of the day, right? So we're thinking about, if you don't need to spend hours cleaning kits and processing devices, what does that mean for you? You don't even need to think about logistics at all and just trust that you have a partner that can fulfill that for you. What does that mean for you? And so that combination of deploying tech as well as services, I think is really our core focus. And again, can't be transactional, right?
Yeah.
It needs to be ongoing. It needs to be a part of that broader partnership where we're continuing to push each other to be better.
I love those ideas. Grace?
I'm absolutely fascinated with the whole conversation. I'm completely pro hospital at home and applaud everyone that's working to advance this. What I'm not hearing is the recognition that many patients and families have been doing their own version of a hospital at home for at least the last 2 decades out of need to survive. So I'd love to hear, what opportunities are you taking to bring patients and families living with chronic illness, life-altering, life-limiting conditions, perhaps surviving care partners who cared for someone for a very long time, that person died, to find a mutually agreeable sweet spot where, hey, this is how we are actually running a hospital at home. How can we partner and co-design this? Because patients and families definitely want this, but I don't see enough opportunities for us to bring our perspectives and lived experience to the table.
So I'd love for Sinai and Mayo to answer this, but in one nuanced way, which is more practical, and that is let's assume that you had the partners at home. How would you get it paid for, right? Because that's your number one problem. Is it's a financial logistics problem rather than the physical logistics problem. But financial engineering is the real reason many of our problems exist. So start with that and then say, okay, how could we partner with people who are already doing this today?
Sure. I completely agree with you. And I think that is engaging the family and engaging really our patients and family is really what will get us to the next phase of that Uber instead of that Uber many years ago. So one is the payer. We all know that continuum of care, that care from acute to post-acute to all the way to chronic care and also urgent care at home is what people want, what we want. But we don't have a payment mechanism right now, not systematically. We have been doing this. We try to do this. We negotiate with individual payers, but it's very arduous and it's very difficult. And when you don't have a financial model to pay for it, it's very hard to do. And absolutely agree with you. When we do have home-based care, we involve family and friends and caregivers in the care of that patient and the planning of the subsequent care plan. And so we just did a study and we would look at our patients and we did chart review of 100 patients. We found that at the very least 80% of these patients, we involve not just the patient, but when the day-to-day care, we involve with family 80% of these patients. And we provide language congruent care, culturally congruent care, and also engaging with the outpatient team as well, like all the outpatient team. So definitely, I think that's where we need to go, but we also need to work on the payment model itself.
In theory, you could say a cash pay could theoretically connect the dots, but Michael and then Seth and
Question in the corner, just to.
okay, yeah, we'll grab that question here. Just let Michael answer, and then we'll go over there.
Yeah, I mean, I think every time we build a different tier of virtual care at Mayo, we always sit down with physician, nurse, administration, and patients, because I always ask the same 7 questions every time we build something. Is it feasible? Can we actually do it? Can it turn on? Is it is it doable? And then is it safe? Is it safe for patients to get this care? Will it be acceptable to providers and patients? Will they accept it in their lives? And then will they prefer it? Will they want this? That drives the next one, which is scalability, then financial viability, and then portability. So we don't reinvent the wheel. We can move it on to the next side. You have to answer those things. We do that with patients all the time. We can talk about payment models forever.
Yeah.
I will tell you that a 2-tiered system for home hospital payments will not work. I mean, if you get paid $5,000 in the physical hospital and $3,000 at home, even though we say we have a problem with beds, people will find a way to put people in hallways and in tents, everything else to collect the extra $2,000. So the solution, my own personal opinion, even outside of Mayo, is you got to save money and pay $3,000 for everything. Actually drive down the cost for bare care units. For pneumonia, it's IV antibiotics, labs, and so on and so forth. And if they need the building for a bronchoscopy, for a scan, for a surgery, then you get extra payments on top of it. So now we're incentivizing driving people home because it's lower cost, but the hospitals still get their money for the things you need a building for, which is these extra little things. That type of payment model will actually work in this. But if we're going to do that, we need the payers to, if I'm not going to get $5,000 anymore, I'm going to only charge $3,000. They have to pass that on to the patients, because if they just line their pockets with the extra $2,000, then what the hell's the point of the whole thing?
Great.
yeah.
Rachel, go ahead.
I was just going to say, I think one of the things that, I mean, a lot of people in here are caregivers, and at the end of the day, we're here because we want the best for our patients. I think one of the things you have to think about is what's the cost of not doing it.
Yeah.
And, if you look at right now, the amount of people coming back into the system, readmission, there isn't a health system I'm talking to today that isn't struggling with readmissions. And if you can drive down some of those costs of readmissions in your organization, you're creating those additional dollars to spend elsewhere. I mean, that's really, you're driving down length of stay, you're discharging early, you're doing all of these things. So you're turning over those beds and you're increasing the revenue. I think you really just have to look at it overall, and you have to have, leadership that understands the bigger picture, and so that you can do a better job of saying, here's the cost if we don't. Because I think that cost is exorbitant, and it's just going to get more and more if we continue to go down the path that we are. I also would say one of the things too is once, and I don't know who owns physician groups and what your models are within your organization, but there are ways to augment the cost of what you are doing in the home by having just basic monitoring, patient monitoring. And what, again, we still are not knowing what's happening with reimbursements and what's going